Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello and welcome everyone. My name is Renee Garrett and I'm your Speech Therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Rebecca Weber owns and founded Navigating Neurospeech Therapy, NNST. As a guest on this podcast, she does receive an honorarium from Speech Therapy PD. She has no relevant non-financial relationships to disclose. My financial disclosures are that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on Speech Therapy PD, I do receive financial reimbursement. I'm also an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I am the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat box or the Q&A box and will be answered at the end of the presentation. Now, without further ado, we welcome our guest, Rebecca Weber, MS, CCC-SLP, CBIS. She is the founder and owner and primary speech-language pathologist at Navigating Neurospeech Therapy, NNST. This practice is an adult-focused private practice. She specializes in providing speech, language, and cognitive therapy for those who have had a stroke, suffer from a concussion or brain injury, have mild cognitive impairment, MCI, or neurodegenerative diagnoses such as Parkinson's, multiple sclerosis or MS, primary progressive aphasia or PPA, and dementia. Rebecca is located in South Jersey, right outside Philadelphia, provides in-home visits and telehealth services in the state of New Jersey. With over 12 years of experience in various settings, Rebecca founded her practice due to a passion for person-centered care and filling a gap for needed outpatient therapy within the community. Welcome, Rebecca. Thank you so much for joining us.
Thank you, Renee. Thank you for having me. I feel honored and pleased to be here.
Oh, good. I'm excited because this is one of those things that's kind of like for the, outdated old people, younger terms, my jam. It's my jam.
Yeah, this is definitely a topic I love talking about, so intriguing.
Yeah, and it's interesting because a lot of what I've heard in the past, like earlier in my career, was we didn't always refer to it as mild cognitive impairment. A lot of times what people called it was higher level cog, right?
Mm-hmm.
And so I would get a lot of feedback from other SLPs and where I worked and say, "Oh, I don't treat higher level cog. We don't need to touch that." So I think it's a great place to start in sort of defining what mild cognitive impairment is and what maybe. Well, we'll start there. What it is.
Yeah, that's fine. Actually, would you mind? I'd like to start with discussing a little bit about what exactly is considered the normal aging range and then kind of lead that into how that compares to mild cognitive impairment. Normal aging, I think that this is something I've noticed with a lot of family members and parents of friends that they're unsure of that line between the two. So normal aging would be any cognitive decline that occurs in the absence of a diagnosis or a disease. So there are somewhat predictable irreversible changes that are going to happen to the brain. If we're looking at our memory, language, executive functioning skills, especially with memory, there are things that are happening that don't often disrupt daily life at all. So, I was reading an article the other day, and I think it actually said somewhere even in our 20s or 30s that you can actually begin to have changes in your memory and your executive functioning where you're already starting to decline in your 20s and 30s. So that occasional time of forgetting names or appointments, but often demonstrating the ability to recall them, occasionally misplacing an item, your cell phone. I know I'm definitely known for that. Thank God for my Apple Watch ping, but usually able to retrace your steps and locate it. With your language, having some delayed or slowed processing, difficulty with word finding, and with executive functioning, sometimes, just having awareness of errors when you're doing your finances or paying your bills. So as individuals get older, some of these errors are common. And as long as, there's that awareness of it, that ability to self-correct, and it's not often disrupting your daily life, it's not really anything to be of concern, especially with developing routines and planning and having your daily routines that if you have flexibility when things are going to change and things are going to occur. Now, when we go into mild cognitive impairment, you're going to notice some subtle changes in memory or thinking problems that are a little bit greater than normal for your age and that are serious enough for you to be noticing. They may not affect the ability for you to independently perform activities of daily living, and they're often confused with normal aging, but not typically a part of that aging process. So the DSM actually defines mild neurocognitive disorder as a condition in which individuals demonstrate cognitive impairment with minimal impairment of instrumental activities of daily living. So it's really emphasizing that minimal. Okay. So it's definitely something's occurring, like you said, that higher level cog, but it is not necessarily. So if we're going to break that down into some of those cognitive domains that I discussed with normal aging, such as memory, this is where individuals might start to more frequently lose track of the date, more frequently forget and misplace things, and actually start to forget about appointments, start to maybe become more reliant on, using external aids or relying on other people. And I do want to emphasize too, when I talk about MCI here, especially through this whole hour, there is a lot of grays, like even between the normal and the MCI and dementia. It depends what you're reading and what resources you're looking at. The research is like really fine tuning it, but there's definitely that gray area. So when I refer to MCI, I'm also thinking about MCI and beyond. Sometimes that MCI can actually be, which we'll get to later, like earlier onset and turn into dementia eventually. We'll get to talking about that more later. But so that increased reliance on those memory aids, and that might be a little bit more of a red flag if it hasn't been your baseline. When it comes to those language skills, comparing that to normal aging, you're going to find that you're going to have more trouble naming familiar objects, probably more frequently using the wrong word, maybe repeating yourself more in conversation and having a little bit more difficulty following the conversation or just appropriately joining in with a discussion. The word that I like to think of when it comes to those executive functioning skills is an increase in overwhelm. So I find that planning, that organizing, completing familiar tasks for individuals just seems to become more overwhelming. It was something that was like much easier, like if you made an error, you caught it, or it was but it becomes much more difficult to manage finances and possibly even sequence and follow a familiar recipe. Maybe you're checking the recipe a little bit more frequently and having a little bit more trouble organizing your groceries. I've had somebody say to me that they find that they're more reliant on driving with their GPS, even though they know where they're going. They just feel like they need their GPS. It gives them that comfort and reduces that overwhelm. And so with mild cognitive impairment too, typically you're still not really going to see, personality changes or mood changes changes, but you might see some more increased or co-occurring depression or, irritability, and maybe a little bit not as adaptive when routine is changed. Like people like to set up their systems to kind of help with what they're struggling with. And if things don't go the way they want, they might not be as adaptive. Another thing that I usually think about when comparing normal aging and mild cognitive impairment is kind of those visual changes and the visual spatial changes. So when mild cognitive impairment is kicking in, you might notice just a little bit more trouble judging distances. And that is possibly why people are becoming more aware with driving and, unsure about where they're going or distances between cars, and maybe just an increased fall or an occurrence that might have to do with those visual spatial skills. So yeah, that's a little bit of a summary about, what MCI is. So there's many factors that can contribute to the progression of MCI, and there's a couple of, different things that we want to focus on. I'm actually going to talk about I wanted to talk a little bit about the subtypes of MCI. This was something that I do find pretty interesting. I didn't know that there was initially 4 different ways to kind of look at this mild cognitive impairment. And I've actually found this very useful in my evaluations and my treatment now, and kind of trying to think about where the individual might fall a little bit to focus on those goals and possibly what might be a cause of the mild cognitive impairment if that hasn't yet been determined. So the first one that I've seen a couple, like the most often, is the amnestic MCI. It's single domain. That would be primarily memory with no involvement of any of those other cognitive domains. So this is the one that I think is most associated with a prephase to possible Alzheimer's dementia. That's like one of the first things that you're going to see. And then the amnestic MCI is multiple domain, which memory is primarily affected. However, you're also going to see other cognitive domains impaired. Non-amnestic MCI, single domain, would be impairment of a single non-memory cognitive domain. A good example of that might be aphasia. So someone that is just presenting with that anomia and word finding difficulties, but really isn't reporting much of the memory or the executive functioning. And then the last one would be the non-amnestic MCI, multiple domain. So this is where you would have impairment in 2 or more cognitive domains, neither of which involves the memory impairment. So I believe it's Parkinson's that might fall under this one a little bit if you start to see not that memory, but you're seeing those visual, spatial, and some of the other cognitive difficulties. So studies show too that a greater than 95% accuracy with a mild cognitive impairment diagnosis is noted when both memory and executive functioning tests are used. So, at first too, I found that a lot of MCI often presents, at least people are reporting those memory changes, but how important it also is to consider those executive functioning deficits as well, and looking at all of it, not just fine tuning because they're reporting memory, not just looking at memory, but making sure that you are probing further and investigating all of the other domains of language and executive functioning. And that when you do see impairments with memory, executive functioning, and visual spatial domains, that there actually is also a higher probability in that case for MCI to go down a dementia path, because it is addressing, a variety of different domains. One thing that I also think is so valuable too is that I read somewhere was that MCI should be considered a clinical syndrome with a heterogeneous underlying pathology and not a diagnosis in its own. So that's kind of, to me, just so important and critical in determining my evaluations, what sort of assessments I'm going to give, and where to go with my treatment, because I want to kind of fine tune what is the primary initial focus of whatever is underlying this that we need to address. So yeah, to break that even a little bit further, studies have shown and research has shown that 1/3 of individuals with MCI, it can actually progress to a dementia type. I forget the percentage exactly for specifically Alzheimer's. I don't know if you by chance happen to know that, but 1/3 of it is can remain the same. You with and not get worse and not get better. And 1/3 of a diagnosis of mild cognitive impairment can actually be caused by other health issues that might be A, preventable, and B, treatable. So that's even two angles that you can take in your approach to therapy, too, how we can prevent it from happening in the first place. This is someone that doesn't have a diagnosis, but also how we can prevent things from getting worse or treat the cause. So other causes of mild cognitive impairment, aside from an underlying dementia diagnosis, might be side effects to medications, blood pressure, diabetes, sleep disorders, mental health problems, vitamin levels, thyroid disorders can affect that, blood pressure. Yeah, so all of that's why, one thing that I'm very passionate about is kind of increasing this education for that what mild cognitive impairment is, and that it doesn't necessarily mean that you have a diagnosis of a dementia, and that you should be evaluating to see, is there something else medically that I'm not addressing properly that I should be doing in order to, get to the root of the cause and hopefully prevent this mild cognitive impairment from worsening or turning into anything else. So
Well, and I think that's a good point too, because one of the things that we saw with long COVID was similar issues with the cognitive impairments that came about, which totally makes sense if you're understanding pathophysiology behind, you know, our folks who have, oh gosh, the word left me, that have TBIs that are related, or not TBI, I mean, not TBI, more like an acquired brain injury that's related to a hypoxic or anoxic event, right? And if
Mhm,
you're having
mhm.
trouble breathing, it makes sense that you might have a cognitive impairment that's maybe mild once you're recovered in nature, but it's lingering. And like you mentioned, the symptoms tend to be atypical from normal aging. And I explained that a lot when, I was talking to my family about my mother in law when she still was alive with her dementia and early onset. Even early onset for her at the beginning stages, when I was noticing things, the things that I was noticing were atypical. Things like you mentioned about visual spatial, like hitting a barrier at the gas station, or she had a couple of falls because she misjudged the distance in the house, or leaving a pan on the stove when she left the house that was still burning,
Mm,
or leaving the water on in the upstairs bathroom and leaving the house. Those are things that are not typical aging related things. Like you mentioned, maybe you forgot to pay a bill on time, or you missed an appointment, because sometimes that can just straight be overscheduling
yeah,
or life, right? When you have other people that you're caring for, that can be life. But if it's
yeah.
consistent and it continues to persist and it becomes a pattern, that's what you're looking for, is the atypical plus the pattern. And that's when you
Mhm.
start to wonder if it's more of a cognitive impairment versus just one of those isolated things that we all do.
And I think another thing is that a lot of individuals, I think sometimes it's more like, oh, I'm just getting older. Or I spoke with my friends and she's doing X, Y, and Z too. And it's just kind of like, like, let's take a step back and think about what is she doing also. Let's not compare. And that's not a typical aging thing, and I think that as generations get older, and dementia rates get higher too, we're becoming more and more in tune with what to look out for, hopefully, and spreading the word more, and not just for parents or grandparents, but also now for ourselves, and what to think about, what we can do for that long run, and what are we looking out for to try to prevent ourselves and keep ourselves to having healthy brain habits and on the right track for our families. So
Yeah, and I would imagine, going back to something else that you said when you're talking about defining the domain, it's, you said helpful for assessment and helpful for like goal setting, but I imagine it's also helpful for the education that you do
yeah.
with families and caregivers, because it
hmm
gives another layer when you can explain it in those terms and then back it up with research. Even if they're not reading the actual article of research, if you can provide that to them, a lot of times it's peace of mind for people that are not in the field.
Yeah, exactly. And I do. I'm always considering that family education and caregiver education, just even as a part of my goals and a part of the treatment plan in general, because oftentimes, as much as possible, you want them to be involved, whether regardless of what the quote unquote cause or underlying pathology of that MCI might be. But I think it's, a lot of individuals are oftentimes MCI is not really well known, and they're just provided this diagnosis and sometimes just sent on their way, or don't have the diagnosis and know that something's up. But imagine just being given a diagnosis and it's not familiar to you, and you don't really know what it means for you. And that's where I'm kind of trying to come in terms of assisting and intervening with individuals that are particularly interested in learning more and doing everything that they can to maintain their best self.
Yeah, and I think you touched a little bit on causes as far as some of the underlying disease processes that might be early onset, but for things like concussion and TBI, we see that too because again, we see this a lot in athletes. We see this in people who've had repetitive concussion histories or active duty or retired military members who have had injuries such as blast injuries or just, TBIs. Maybe they had a combination of events that have happened. And that's a lot of times what we see happens is they get discharged from services because they got treatment at an inpatient rehab, or they got treatment through a military treatment facility, or there's a case that I've talked about a couple times on the podcast where I had a patient who got diagnosed with post concussion syndrome, but she was unconscious at the scene and airlifted to the closest uh, level one trauma hospital. That's not a
Mm,
mild concussion. You lost consciousness for several unaccounted for minutes and you're airlifted.
mhm,
That's not. But they were classifying her as having an MCI, but she
mhm,
had far more reaching deficits, everything from the mental health stuff that you mentioned. Again,
mhm.
that's a normal response to any kind of injury to your brain. When we're thinking about those chemical neurotransmitters and how they react to this change. And it's similar to like what you were talking about with the possible transition from an MCI into a more uh, concrete dementia diagnosis. And I think
Mhm.
it's a good example.
Yeah, no, definitely. And I think when we get a little bit further down, I'm going to talk about some different scenarios of how speech pathologists can intervene or where we might find ourselves in terms of the plan of somebody with mild cognitive impairment. So it kind of ties in with that. But so would you like me to discuss a little bit about the changes between MCI and dementia, or okay. All right. So
Yeah, that'd be great.
okay, so the main difference, I won't go too specific into each domain, but I did want to just emphasize that you're going to start to notice a significant the DSM-5 discusses a significant cognitive decline from a previous level of performance in one or more cognitive domains. And the difference with this for mild cognitive impairment is that it does begin to interfere with independence and everyday activities. So, uh, excuse me. MCI is a less serious cognitive performance and symptoms, where dementia demonstrates that more serious cognitive performance. And then with MCI, symptoms do not significantly impact daily living. And then when you start to transition into that dementia level, everyday activities become more of a challenge. So that's where you're really just going to see everything kind of shift further down that line of impairment, those word finding difficulties, the language difficulties, the memory difficulties, executive functioning, all those areas, mood and personality. You're going to notice an extreme difference, from that mild cognitive impairment range. Excuse me, I'm just going to take a sip of water.
I was gonna say you got to do your voice hygiene, your vocal hygiene.
I do. Got to practice what we preach, right?
Yeah, I've got mine. Cheers. Cheers
Always,
with water.
always. Always. Okay, so I guess in addition to this, one of the things that we were going to discuss was ways that SLPs can provide treatment to patients with MCI, and just kind of really getting an understanding of the critical role that we might have with assessment and intervention. So I decided to just start with this about discussing 3 or 4 potential scenarios that I've either come across or that I know others have come across where the SLP has played a role, and they're all at varying levels of intervention. So the first example to discuss would be an SLP that might be in more of that inpatient level or that subacute, where, maybe an individual comes in with a fall or an injury, and you're asked to screen them, and maybe family reports and the patient's reporting that there's no cognitive problems, and you notice that something's a little bit off. They had scored a couple points off, and there's really no other underlying possible reason. There's no UTI. You check for a UTI, you ask the wife or the caregiver or whatever, have you noticed any changes? And they're like, oh, I did notice this and that, but they're just getting older or whatever. And I think that's where SLPs, to do our due diligence and just kind of making sure that we just investigate it a little bit more, maybe mention it to the physician, talk to the family member, test a little bit more, and just see if this is something, maybe like what caused the fall. Maybe the fall was due to some visual spatial difficulties, or, just make sure that this individual isn't just necessarily just passed on. And I know it's in reality it's not always easy, juggling all of this in these settings, but just something to be mindful of, that you want to really investigate those mild changes, even if they aren't something that seems to be very, very significant. Another example that I was thinking about was it happened. A client that I had was when I was working in the outpatient system, in the outpatient hospital systems. I had a client who came in who had a full workup, actually came in with the diagnosis of MCI already, and they called for treatment due to concern about the cognitive changes. And we had, what the diagnosis was. I was able to do my own evaluation. We were able to adjust the goals, and it seemed nice and straightforward, and, do the education component about, what they could do for their brain health and what they could do for strategies. And that was just, another pretty straightforward scenario. And then another example where an SLP might come into a diagnosis would be, I had a client who is currently awaiting a full workup with neurology, but had pursued therapy because they know that something's changing. They know that something's up. They're still kind of in the process, and they reached out themselves, and they're motivated and driven. And this is like exactly what I love to work with, because they're there because they want this work, and they're in it for, their long haul. So in those cases, and in this situation, even though they were awaiting a full workup for neurology, we were able to do our own comprehensive evaluation based off what they're reporting on memory and problem solving and executive functioning, and our own patient reported outcome measures, and our own discussion about what their goals are. And, it's not going to be a lot of sessions at this point in time, but at least enough that we can go over the things that they need, provide some of the tools, provide some of the education, and that they're not just feeling, left out in the dark, like that they don't know what's really going on. And hopefully we'll get some valuable information too that's going to even guide our treatment more once we get the finalized neurology report back, that we've been waiting on. And then another scenario too, it's kind of a little bit further along, but I had a client come in with the diagnosis is mild cognitive impairment. However, they're finalizing currently, and I'm a part of the team in terms of reporting on investigating Alzheimer's, primary progressive aphasia, like trying to wean out some of those symptoms and trying to wean out what's going on for that formal diagnostic. So I had stepped in, we were waiting for an update MRI, and it's very interesting too, because for this individual, that it's clearly presenting as a PPA. Initial symptoms are language, but all they've been given is that MCI diagnosis. So, we're able to intervene. And so what I was saying though, it's presenting as a PPA, but the scans and the MRIs are showing possible potential Alzheimer's. So, we're piecing the puzzle pieces together, trying to figure out, I guess, the diagnostics PPA can present and then progress into that Alzheimer's type dementia. But I think that these examples were just showing a little bit how SLPs can help with diagnosing MCI, helping those with MCI improve their cognitive functions, possibly working on reverting back to normal cognitive aging, possibly slowing or preventing conversion to dementia, also supporting individuals and family members as they navigate a diagnosis. Like in all of those four examples, I just thought that that was a little bit of a different perspective in stepping back and looking at how SLPs can contribute to the MCI world.
Yeah, and I think going back to, especially in inpatient rehab or some subacute rehab settings, you're working typically with a multidisciplinary team. So a lot of times you get really good feedback and input from physical therapy and occupational therapy
Mm-hmm.
on the patient's performance or the carryover of directions from therapy session or the carryover of techniques that are more compensatory or new strategies that they've given for everything from energy conservation to preventing falls. So we get a lot of good information from that. And then the
Mm-hmm.
other thing I wanted to say was the informal assessment piece is often really important. And uh, I'm teaching an aphasia class this semester, and I was actually going to talk. I did a little bit of that last week, looking at the psychosocial model of how we treat aphasia, but I'm going to talk tomorrow to my students about some informal assessment measures. And uh, because a lot of times I think we get so hung up on these standardized tests, and we have to have these for insurance and we have to have this for that. And we have to go back to the physician if we want extra visits, if you're an outpatient. And there's a lot of layers to it. But
Mm-hmm.
oftentimes, what people forget is that we get a lot of information just by talking to the caregiver, whether that's family, whether that's children, whether that's neighbors or close friends. And you do start to see, like, oh, yeah, we play Bunko every Wednesday, but Marge forgot the last 2 weeks or whatever. You get
Mm-hmm.
information like that that does, it's informal. But again, we're sort of the investigators of this and trying to determine, okay, is this something that we need to be more concerned about, or is this something we can do some strategy treatment for, run through some activities, and give those, like you said, visual supports and other external aids like using the calendar. Most people now, I mean, I won't say my age, but even for me, when I was younger, I knew everybody's birthday and everybody's phone number. Don't ask me that anymore because guess where it's all at? It's in my
Mm-hmm.
phone. So if your
Mm-hmm.
number's not in my phone and you call me, I'm not going to answer.
Yeah.
So
Yeah, it's so
I think,
true.
and it's not a cognitive impairment. It's just things have changed as far as
Mm-hmm.
our reliance on those external aids that we don't even really think about until we get an example like that.
Mm-hmm.
But again, we're looking at things that are a little bit more consistent patterns and maybe atypical from what we would expect to see from our patients. So I think the informal assessment piece is a really, really important piece.
Yeah, definitely. And that does kind of segue into talking about that assessment and treatment section. And one of the things that I was going to emphasize that, I guess you could say even do struggle with is I am very big on setting those, meaningful goals and using motivational interviewing and using prompts. And you do need to still make sure that you are utilizing the proper formalized assessments in order to for insurance reasons and you do get valuable information from that obviously,
Yeah.
but yeah, not one test, can diagnose MCI. It's a process that involves so many different members and sometimes time. And one of the things that I was going to mention later was just that there could be a lot of false diagnostics too for something like this. It depends on, how you're going about the process, or people that are undiagnosed that should be diagnosed and it gets overlooked. So with assessment, I think you just really have to take a step back. And I really like to focus from a speech pathology perspective on specifically what do they want to be working on. And I know that it is a barrier because it depends on what setting you're in. It depends on, the client and what kind of goals that they have. But by utilizing those patient reported outcome measures and really listening to them and utilizing goal attainment scales, that's where I really find the bulk, and talking to family members and caregivers, the bulk of what our actual goals are. So do you want me to, I'll just talk a little bit about specific assessments? I guess we'll do that. Okay.
Yeah, that's great. Yeah.
Okay. So yeah, the one patient reported outcome measure PROM that I do love with this population, I've found that most individuals with MCI that I have worked with have had memory problems, is the MMQ. I'm sure you're familiar with it. It's the Multifactorial Memory Questionnaire. It is a questionnaire that's broken down into 3 different subtests, and it looks at a person's how they feel about their memory, the memory mistakes that they're making, and their use of their memory strategies. I really love this. I've used this across the board, not just MCI, but with a whole variety of different diagnoses and goals. But I love how you could see I've seen variability where you might have somebody who how they feel about their memory is like very, very low. And then they might be like using all of the strategies there already. Or you'll get somebody who is feeling okay and they're not using any of the strategies. And like, I just think I'm always curious to see if there is some variability in these questions, and really try to pick out the areas that they are rating themselves low on, the areas that they are really struggling with, and bring in some of those treatment methods to then properly intervene with those sections of their memory. There is also the functional activities questionnaire. It just measures functional changes in independence with ADLs. And if you're concerned, or if this is a dementia progression, possibly, there's the quick dementia rating scale, which differentiates between normal aging, MCI, and dementia. So not necessarily a prom, but like more of a rating scale, but still gives you valuable information in terms of goal writing. Now, as an SLP, I am in the outpatient setting, obviously. So far, either a client, like I said, has the diagnosis of MCI already, and then I hopefully get access to any previous testing, and then I provide further assessments in ways that I can help fine tune our goals for treatment. Or an individual might not have a diagnosis, and they're coming because they know something's up, and hopefully I can help be a part of that initial diagnostics, talking to them about baseline changes in cognition and being a piece of the puzzle. So in that case, I mean, like I said, not one test is the test to diagnose MCI. So it depends what you're really going to be looking at. Like, what is it that they are struggling with? So if they're reporting memory aside from the MMQ, that formalized assessment, you might want to look at like some sort of list learning or paragraph recall or verbal fluency or digit span assessment. You can find, some of those. There's the R bands, the repeatable battery for assessment of neuropsychological status, the CLQT, which I recently heard it called the Click It. I don't know. That was a new one. I don't know if you've heard it called the Click
No,
It. We'll have to take a poll on that, because that blew my mind. So, but the CLQT, the California Verbal Learning Test. Oh, well, for language would be the California Verbal Learning Test, the Boston Naming Test for language, Philadelphia Naming Test for language. Just maybe getting some sort of a measure on what their generative naming is, or, I try to make sure that it is some valuable content and contextualized into their immediate environment when possible. And then for me as outpatient, of course, I've been trying to utilize anything that is freely available. And I had recently gotten my hands, well, not recently, I don't know what I'm talking about recently, but a few years ago, I got my hands on the Brisbane evidence-based language test. And I find it valuable. I can use it in my own way. It doesn't have like a fantastic specific school, but the information and the way that it breaks it down, and the fact that it is easily and free and accessible, has been fantastic. So that I've utilized for individuals with MCI that are having those language impairment. There's a high level test for that. So that really tunes out some of the I guess lower level information, and really focuses on some of the higher, harder language skills and larger tests. But a barrier with MCI is people test out on a lot of this stuff, or they test really well, and that's exactly, you can offer these tests, a list of them. You could try take components from all of them, but that is definitely a barrier, is depending on where they fall with MCI. That's why their report and talking to them is the most, and family members, is the most valuable in goal writing. Um, I'm trying to think. Oh yeah, and so if you are considering or a potential progression into dementia, or if they have an MCI that likely is going into early onset dementia, there are screenings for that too. I know there's the dementia screening, AD8. It's a dementia screening interview. The Sydney Language Battery. I recently was looking at that for PPA. It helps with differential diagnostics of PPA, frontal temporal dementia rating scale. And yeah, I'm not going to say that. That was fine. But yeah, so my point was too, is that it's very hard because there's not one test that diagnoses these. You really have to use your clinical skills to establish what are they reporting that they're struggling with, and how can I pick up on these skills, and how can I also get the information from them that I need more subjectively to write those good goals to help them with their progress and help them with where they want to be with this diagnosis.
Yeah, and I think it's an important part because there are a lot, like you said, a lot of good places we can look for information when it comes to assessment. But then looking at treatment, it's the same, right? We get a lot of good information from the looking at treatment more functionally and what their skill set is. Are they still working? Do they
Mm-hmm.
have responsibilities that they caregive for? A lot of people that are in their 50s, 60s, 70s are caring for their grandchildren, or they may
Mm-hmm.
have a child with a disability that's now an adult with a disability that they're caring for. And so sometimes those pieces of information help guide our treatment because their need is going to be different from someone who's 65 and retired and doesn't really, isn't really caregiving for anyone else. Maybe they volunteer or maybe they just have hobbies, but their needs are going to be markedly different from someone who has a responsibility to care for another person or is still employed.
Yeah.
And even again, even in a volunteer role, I know like with my father-in-law, he volunteers a lot at church and he's had a lot of health issues in the past year. I would say, I hope he doesn't listen because he'll be mad at me, but I'm pretty sure that some of the stuff that he experiences is not normal aging. He's going to be 82, but there's some things he does sometimes where I'm like, I don't know. I don't know about
Mm-hmm.
that. But again, looking at what his day-to-day needs are and, is he still able to function and do things like, again, those functional things and safety things like managing medications, paying
Mm-hmm.
bills, staying on top of household maintenance, all those things like that we do day to day, that you don't think about those things until it becomes a challenge or until
Mm-hmm.
you notice a difference in how you're able to complete, or if you're the patient, how you're able to complete those tasks.
Yeah, no, and I feel that statement to my core with not saying too much on the podcast, but I just feel it to my core, just in terms of understanding from all angles as a speech pathologist and as a daughter and as a family member. And yes, just we do the best that we can in all scenarios, trying to, educate and increase awareness and just keep an eye on things and make sure we're good as long as possible.
Well, and I think another place, because I love talking about TBI and post concussion syndrome, and I
Yeah.
think a lot of times people would classify some people with post concussion syndrome as having an MCI.
Mhm.
Certainly, people with TBI who are maybe their TBI was impactful for their life, but maybe it wasn't as severe as some of our patients who, like our motor vehicle crash patients who they're intubated at the scene and they're intubated for a couple months and they wind up having a trach and peg and swallowing issues and all these other things. Sometimes we
Mhm.
get patients who had a motor vehicle crash that was more of like a coup contra coup injury
Mhm.
with a whiplash. And they have these changes cognitively that are really, for the most part, are more resolvable than they might still have long lasting impacts, but it's not as noticeable.
Mhm.
Again, particularly in our younger patients who are physically in better shape or younger brains, all that kind of stuff. So, do you have any cases like that you've worked with or seen?
Yeah, I actually do right now, and it's very interesting because I see a lot of parallels in terms of the type of therapy that I am providing, and just identifying those practical return to work slash is working, that it's just really about much different than, everyone is different, but that's the goals are focused on this is what I need for work. And like, how am I going to do this at work? How am I going to get through my work day? And just really strategizing based off of that, and providing those internal techniques, those external techniques, and also going over all of that brain health stuff, like taking a step back and reevaluating what his routine is. Like it really makes a difference when you're finding out that for his recovery too, that there's no, the sleep patterns aren't fantastic, or that their diet is also not great. And, just you
Yeah.
want to look at all of those, or there's no, needing to socialize a little bit more, just kind of take a step back and look at all of the brain health stuff. There's parallels between this MCI population and the case such as this. And I also saw a lot of parallels with some of my post-COVID, long hauler COVID patients that I had. I haven't seen any recently, like with that diagnosis. I don't know if it's still, are a lot of people getting it? Are they being referred to therapy? Maybe it's just because of where I am in the community right now, maybe, but I was getting a lot of that back
Mhm.
in like 2022.
Yeah, I was
And
gonna say 22 and
yes.
23.
Yeah, yeah. So, I mean, and in that case, I wonder, are there people out there still experiencing those same things, but just being diagnosed differently? And, it's just being addressed from a different angle. I do see parallels in a lot of this higher level cog, depending on, where there goes, are those invisible symptoms, people that are very, very high functioning. I love it. I know some people, it is challenging. They don't love working with high level cog, but I always have. I love it. And I can state
Me too.
the therapist that I am now, even from, 8, 9, 10 years ago when I was in outpatient, a lot of high level cog. I am completely different. So much has changed. Like, just, I wish I could almost go back and just like redo a lot of that, like this, we all learn, like that's the point of this. And that's what, makes this career in this field so fascinating. But my focus on treatment, I definitely just find such better outcomes now and what I've learned and my approach and everything. And yeah, just it's quite fascinating. I love working with a higher level population. So
Well, I think for me, the probably, and I say this all the time. My first love as a therapist was inpatient rehab. I love that setting so much. And the thing that I got to really hone in on early on in my career was that functional treatment piece. So sometimes, and I probably have talked about this on the podcast before, but my very first TBI patient, and I was a CF, so I was new. I was
mhm,
new, and he was a pretty it was a pretty severe TBI. He actually got he was on his motorcycle going home from work, and he didn't do anything wrong. He was in the right hand lane, and there was an SUV in the left hand lane that decided to make a right hand turn into a convenience store and clipped him on the motorcycle and then ran over him.
mhm,
So he was early 30s age wise, very fit guy, worked, had kids. Really, he's a very cool patient. But the one thing that he wanted to do, because I asked him, and this was back when people weren't always asking the patient. There wasn't always
mhm,
patient centered treatment going on. It was like more of the medical model, not so much the social model, where
mhm,
the medical model says we're the governors of the goal setting. We're going to
mhm.
tell you what we're working. And I never approached my sessions that way. But that's a whole other topic of grad school and how I was taught. But the thing that he really wanted to do was to be able to go back to cooking, and we needed a place to start. And so we started with him being able to make a protein shake, because he was someone who worked out quite frequently, and that was his go-to
Mhm,
before, like, a pre and post recovery for his workouts was protein shakes, and he wanted to be able to do that independently. So we had to go through, and we did. It took a long time because he
mhm,
was pretty impaired, but we had to go through and like make an ingredient list, make a tool list. What do we need to do? Create the steps in the process. And because he still was having a lot of behavioral outbursts and things like that related to the TBI, it took quite a few sessions to be able to do that. But I had an SLP that was on the team with me that was like, oh, what are you doing? That's not therapy. And I'm like, but it is. We're working on following directions,
Mm-hmm.
sequencing, organization, executive function, attention, all the things, memory, recall. I mean, there's so
Mm-hmm.
many things embedded in that task, and it didn't look therapeutic to people that were following more of the medical model. But for him, it was everything. And it probably took us like 3 weeks to be able to make that protein shake, but finally we did it.
Yeah, yeah. No, that's fantastic. That's incredible. It is. It's so true. I feel like for a lot of the clients, I mean, even like I was saying, 8 to 10 years ago, just in learning, it was that transition. Like we would do things that they would want to work on, but at the same time, there were still a lot more just paper-based tasks, like,
Yeah.
and the attention tasks were much different, just, and
Mhm.
it's so fascinating to how that the shift in this therapy world has made a difference. And hopefully more and more therapists are picking up on the changes, and more therapists are bringing this into their treatment, because it really, the outcomes I definitely been a lot more successful and rewarding, and from even as a therapist to see. So the one thing, even with MCI, I wanted to just to mention was, have you ever read or heard the book High Octane Brain?
I have not.
So it's by Dr. Michelle Brown. No affiliation or anything. I just recently got my hands on it, and it talks about 5 science-based steps to sharpen your memory to reduce the risk of Alzheimer's. It's got like a whole little protocol in it for that. But what is in the book that really grabbed me is that she discusses by it's Dr. Melanie Chandler on treatment for mild cognitive impairment. There was a study, which I did not read it yet, but this was just, I'm halfway through the book. But there's a program called Habit, Healthy Action to Benefit Independence and Thinking. And it breaks it's they did the research through the study, and it breaks it into memory training, cognitive exercise, yoga, wellness education, and support groups for individuals with MCI and their caregivers. So I'm curious. One of my goals right now is to just really try to find more specific research behind, like, exactly what is the most beneficial for MCI. And the all of these areas, it did show that Habit participants reported improved daily functioning, mood, quality of life, and just a positive change in, like, after completing that program. So that is just something that gets my wheels spinning a little bit when I'm in my therapy sessions, of course, trying to come up with goals that are functional, that the individual wants to do, but also taking a step back at what is the research out there that might be showing, like, if I make sure that I teach this, and this, and we go over this, and this, I want to make sure that we're addressing all of those areas for MCI for those positive outcomes. Because there's nothing worse too than I remember one person that had gotten a diagnosis and is discharged and said, "Oh, could just come back in 6 months and we'll see." And, like, that's the most eager person that's willing to participate. So just trying to make sure we're covering all those bases to know that we are doing everything that we can. We're helping the deficits that are there. We're trying to slow any progression. We're trying to, figure out what's best for their course of action and their treatment plan.
Yeah, and I think that's a good spot to talk about. Some people may not want to pursue a diagnosis and other people
Mhm.
do. So what are some reasons maybe behind that of why they would or would not want to pursue this diagnosis?
Yeah. So I think a lot of people don't want to get a diagnosis because of the stigma behind having a cognitive impairment. I think it's so important to start to normalize it a little bit more, it's become more understanding as a society and accepting of having cognitive impairments or dementia even, and not having, that stigma behind it. The other people, there was actually, hold on, bear with me just one second. I know the Alzheimer's Association is a fantastic resource, obviously, for Alzheimer's stuff, but they do have wonderful resources and information on MCI. And in their 2022 edition, of Alzheimer's disease facts and figures, they had a report that I dug apart as more than normal aging, understanding mild cognitive impairment. And within that, they discussed, why people might not want to seek an early diagnosis and why they would want to seek an early diagnosis of Alzheimer's. So one of the things that really stood out to me too, that you don't always think about, is that it's that stigma, but there's people think there's no cure, so it doesn't matter.
Yeah.
That was one of the answers. And, understandably so. And there are things that we can do to try to intervene and slow a progression, or medicine trials, or whatever it might be. So it is, I want to respect, the fact some people just don't want to know. It is what it is. And that is at the end of the day, but also increasing the awareness that, maybe there might be some sort of options that would help you. And in terms of wanting to plan for the future, wanting to communicate with your family members, addressing concerns ahead of time before it's too late, allowing for earlier treatment of certain symptoms, allowing the family to plan for the future. And there's just, you have to be sensitive for each individual's wants in terms of their awareness of what their deficits are and where they want to go with the awareness of what they're struggling with.
Yeah, no, I think that's good. Because I think there's some crossover there between our patients with aphasia, and I've heard doctors say that before, that, well, I didn't refer them to you because they're not going to get any better. They have aphasia. It is what it is. And I'm just always like, what?
Mm-hmm.
No, thank you. And also, that's the reason I became an SLP, was because my dad had a stroke at a young age and had aphasia. So please don't
Mm-hmm.
say that to me again. This, I'm trying to say
Yeah.
that in the most professional, nice way possible, but like that really is a trigger for me to like really advocate for patients.
Yeah.
Um,
No,
no,
it's
I was
true.
gonna say, if there's a crossover like that for you, and then uh, before we take questions, I just wanted to ask
Mhm.
if there were other things that you wanted to add, or anything else that you felt like was important that we needed to address.
No, I think I was able to cover most of what I was talking about. Just really, like, really emphasizing the fact that even though it's a higher level diagnosis, there is still so much that we can do as SLPs, and that, whether it is helping the individual with improve their cognitive functioning, whether it is helping them slow or prevent going to dementia, helping them navigate the diagnosis. There's so much that we can do with mild cognitive impairment, and I'm just very thankful that I've had this opportunity to be able to be exposed to this population of individuals and find like a little passion within helping and just seeing some of those outcomes.
Yeah, no, I agree. I think so too. And it's definitely a population that I've enjoyed throughout my career working with. But we actually do have a couple of questions, if you're
Sure.
okay with answering questions. Susan earlier said, wondering how one can tell which MCI will move towards dementia to know when to add meds like Namenda or some such. So, Susan, just to clarify, do you mean which domain of MCI, or um, let me see if it's Susan, if you're here?
Maybe she just means like how I was discussing, like one third might go to dementia and one third might
Mhm.
remain the same. Maybe that's what she means.
Maybe.
Can you
Yeah.
read it again?
Wondering how one can tell which MCI will move towards dementia to know when to add meds like Namenda or some such. And ultimately, I would say part of the answer to that, and I'll be quiet after this, is
Hmm.
that of course if there's medication involved, you want to refer to the neurologist or the PCP or neuropsych, because that's not. I don't know that I've ever recommended adding medications like that.
Yeah, I think the neurologist would probably determine based off of like the white matter, or, if they are an APOE4 carrier, that's another variable, or if there's abnormal readings on their PET scan or CSF analysis or something like that. I think that that's how they'll determine based off of the neurological or neuropsych workup that from that's where they'll know. I hope that answers the question, but
Yeah, she said to help provide support to families. Yeah.
yeah.
And I
So
think
you'd probably want to have that confirmation of the subtype from, the neurologist if it does seem to be one that would progress, or they have indicators that MCI is gonna eventually turn into dementia or Alzheimer's.
yeah, so what she said was, for instance, the neuropsych report shows MCI, but function is showing dementia type behaviors.
Hmm. I mean, I would maybe discuss that with the neurologist then. Yeah. See what, because maybe there's been a change. How long ago did they see the neurologist would be a question that I had. And, does the patient report changes since they've seen the neurologist? And just speaking with the neurologist, see what they did test on. Are they planning to do any further testing? And if not, if you're seeing dementia, then bring it up with their provider and see if they can investigate a little bit further.
Yeah, because for us, I know a lot of times when I was an outpatient, it took forever sometimes to get referrals over approved through
Mhm.
insurance and then finally see the patient. They might have seen the neurologist 6 months or a year prior, and they have had
Mhm.
additional changes in that time and space.
Yeah, no, it's true. And I mean, I've had a case where I had someone who said they had the family called. They said that there was a diagnosis of Parkinson's, and I couldn't get the diagnosis. I couldn't get any of the reports yet. So I went in for the evaluation, and in like 10 minutes of the evaluation, I'm just like, this is not Parkinson's. Either that or I need to quit my job. And like, then it was like immediate, thankfully, it was not thankfully for the client, but yes, it was not Parkinson's, and immediately communicating with the neurologist. The family thinks this is Parkinson's. Let's get on the same page over here. So
Yeah. Well, and then Kathy said, "What does the habit mean?" That was from the book that you were talking about, and
oh,
I can
yes,
type that.
it's a healthy action to benefit independence and thinking. I know I have my list of like workbooks that I'm reading and then my list of fun books that I'm reading. And this is my most recent kick. So I'm always open. And if anyone has any other good books, just shoot them my way someday, because I have been enjoying this one, just the breakdown of it and how she specifically does address mild cognitive impairment. So,
Yeah, no, I wanna get my hands on that because that sounds really.
yeah.
I like that holistic approach. I loved what you said too about nutrition and even hydration, which is part of nutrition. But sometimes when people have the MCI or even like a TBI or post concussion syndrome, a lot of times when they're having these sleep challenges, they self medicate with energy drinks, and that could be a
Mm,
whole podcast too because that's such a
yeah.
bad thing for your brain to over caffeinate.
Yeah.
But again, that would be a whole other topic for a whole other
Oh
day.
my, I feel like every little subtopic here could be a whole topic, like assessment, treatment, everything. It
Yeah.
just it's so
Yeah,
hard
it
to
is.
just pick out the very important stuff when there's so much information, but
Well,
and it in oh yeah.
Joan asked, "What is the last name of Michelle who wrote High Octane Brain?"
I think you pronounce it Brown, or it's Braun, Michelle, Dr. Michelle Brown.
Okay.
I have
Well,
this.
Rebecca, I really thank you for joining us. This was fun for me, and I just really like the specifics you brought up about, again, the holistic options and the functional treatments and all the things that a lot of people are doing, and a lot of people just haven't haven't been exposed to it or haven't felt comfortable doing it. So I appreciate you bringing up such great topics and supporting these patients with MCI. And
Thank
more
you.
specifically, I just appreciate you being along for the ride of me just randomly stalking you on Instagram.
I'm honored.
Sitting
Please,
there.
thank you so much for having me. This was a wonderful opportunity. I'm very thankful. And if you ever need me in the future, please let me know.
Absolutely. Absolutely. Thank you again. And Rebecca, we look forward to seeing you again.
Thank you very much. Have a good night.
You too.
Thank you for joining us for this episode of Brainstorms, Functional Neuro Rehab for SLPs. We have a special coupon code for our listeners to receive $20 off any annual subscription to Speech Therapy PD. Head over there to get ASHA CEUs for listening to this podcast and all other episodes. The code is Brainstorms20. 20 is the number 20. We appreciate your positive reviews and support and would love you to write a quick review. Also, subscribe. If there's a topic you'd like to see us cover in the future, you can email us or comment in the comments section or message us on social media. Remember to go to Speech Therapy PD to learn more about earning ASHA CEUs for this episode and more.